Thanks for staying. It's a sunny day outside, but it's a little chilly and it's warm in here. I was going to give you a little more of an introduction and let you know how Dr. Takang and I met. I'll just tell you it was at the Brussels airport, and that's all. But I want to tell you a little bit about him. He's a medical doctor and consultant at the Ministry of Health and the University Teaching Hospital in Cameroon, an obstetrician gynecologist by training, which training was done in Cameroon. While keeping up a medical practice, he has taken on a public health agenda as well, and his research has resulted in important surveys of an epidemiological nature. In 2008 and 2009, Dr. Takang was awarded a Hubert Humphrey Fellowship, one of the most prestigious honors bestowed upon mid-career professionals from abroad by the U.S. government. He spent 1 year at as a Humphrey Fellow at Emory University. He's undertaken to speak on a big topic today, so I won't go further than to say please join me in welcoming him to the podium.
Thank you. Thank you very much. Thank you, Sandra, for that wonderful presentation. As she said, we met by chance, at the airport in Brussels. I just had to borrow her pen, and we started talking, and that was it. And I got to know that she was coming in from Tanzania, and I told her, oh, well, I'm also coming in from Cameroon. And I've been to the United States. This is the second time I'm going to the United States. And the first time I was there was thanks to the Hubert Humphrey Fellowship, which President Jimmy Carter had to start in honor of his very close friend and his very close collaborator, Hubert Horatio Humphrey, who was very interested in international collaboration. He thought that if folks could come around from around the world, to collaborate on diverse issues, they wouldn't be fighting. And that's why, after he died, President Jimmy Carter, who I also had the honor to meet at Plains in Georgia, decided to institute this fellowship that brings to the United States every year about 163 different people from about 90 different countries. And we go through a very, very, very tough process, of selection, and the mid-career individuals who finally get this award, come to the United States. That's how I got involved in public health informatics, and all of that. This year, I also had the good fortune to be selected to do a postdoc fellowship program at the New York University Medical School, where I'm currently undertaking a course on AIDS-related malignancies. And so Sandra and I thought if I came to talk to you guys about some of the pandemics that are going on around the world, it should be able to edify you on some of the things that other people are going through. I like to apologize for the problems, the technical problems we've been able to have. We've been able to resolve this a little bit. What I wanted to talk about was the three main pandemics of the century and their effects on the economies of the environments where they live. One of these pandemics, of course, is malaria. Malaria, we'll look at a little bit about the epidemiology of malaria. Epidemiology is the study, of the conditions under which diseases are usually transmitted. In terms of its endemicity, it's around the tropics. When we talk about the tropics, it's usually around 23 degrees north and 23 degrees south of the equator. This is so because this area has a particular temperature that helps the malaria, the mosquito to be able to thrive, reproduce, and also in the process transmit this disease, which you will see, whose effects you will see in just a little bit. Of course, about 3 billion people are involved in about 108 countries around the world. Although I talked about the tropics, it's not only the tropics. Of course, the world is now like a global village, okay? Some 50 years ago, when Hubert, Humphrey, and the rest were alive, it would take about a week to travel from Africa to the United States. Today, with technology and all of that, it takes virtually 48 hours. But guess what? 48 hours is enough, it's just the life cycle for the malaria parasite. From the time when a mosquito bites you, in the airport in Douala or in the Congo, and you get here to the United States and you start having the manifestations. Of course, if you don't think that this person coming from malaria, from a malaria-infested zone, you would look for everything else but malaria, and your patient may die just under a watch. And that's the reason why we think it's good to expose some of the people who are currently in training, so that in the event they have somebody who is coming out from Africa and has some of the symptoms which I'll present in a little bit, they would be able to address the issue adequately and in time. Of course, there are about 243 million symptomatic cases that are diagnosed annually. If you want to compare this, a plane crash, maybe about 200 jumbo jets annually would crash to be able to cause the kind of damage that malaria would cause. About 863,000 deaths are reported around the world annually. You see, it's a dire situation, but I think the international community has recognized that, and you will see in just a little bit some of the things that people are doing. Of course, 80% of children below the ages of 5 in the tropics, according to the World Health Organization, are usually affected. Who is involved? Everyone. Everyone is involved. Children below 5, especially pregnant women, usually, when you're pregnant, your immune system drops. And because your immune system drops, you're not able to fight adequately against the malaria, and so the effects of the malaria usually are more severe. Besides, the malaria will cause anemia, and will cause your red blood cells to be destroyed, and so your baby, who relies on your blood for its well-being, would be also affected. And that's how women who come up with malaria come up with abortions in the first trimester, but by the time they get to the second and third trimester, they have premature deliveries, and the babies who are finally born would have low birth weights and are therefore exposed to perinatal death and so on. Okay. Of course, travelers from endemic areas. So there are so many people going out to Africa today for diverse reasons. Some are going just for tourism and so on. And when you leave the United States, you've never been exposed to malaria, so you don't have the antibodies to fight against malaria. So when you leave here and you go to Africa, or you go to any of the zones, which you will see in a little bit, you have to make sure you have your anti-malarials at least a week or two before you embark on such a journey. So that's one of the other reasons why I decided to make these presentations, because people who live here usually come out there and their symptoms usually are more aggravated, much more than for the people who are living in Africa. Of course, malaria is transmitted by the female Anopheles mosquito. It's just the female Anopheles mosquito. Do you know why? Because the female Anopheles mosquito needs blood for its eggs to mature. There is no other mosquito that transmits malaria. It's just the female Anopheles mosquito, and it goes to pick blood from you, and in the process, passively transmits the malaria into your system, and then the parasite takes over from there. Okay? I had a movie which I wanted you to watch, you know, but unfortunately, the problems we've had, the movie has not been able to come on. So we'll go into YouTube and probably I'll pull it up for you. Now, when we look at the hematological features of malaria, when you find malaria in the blood, more than 500,000 parasites per millimeter cube, then you start having the symptoms. Usually they're they're in the form of schizons, and 5% of neutrophils contain malaria pigment. So when you see that, you already know that the patient is about to have a bout of malaria. Now let's look at the geographical distribution of malaria. We'll see. Are you seeing my mouse? Yeah, I told you malaria usually is just within this belt. Okay? That's about 23 degrees north and 23 degrees south of the equator. So if you look at the countries, you have the Americas. You look at in Africa, you have basically this belt that is south of the Sahara Desert. Up here, you have the Sahara Desert, and so below, you have all the countries south of this Sahara, which are mostly affected. And when you go across to Asia, you have India, Sri Lanka, and the rest. And this second diagram shows you, some of the areas. Well, it talks about the poverty-stricken areas that I will talk in a little bit about. Of course, I had to bring out this slide because Mexico is just south to the United States, and so people who live in Mexico come up with this disease, and it can always infiltrate. And if you leave the United States and come into Mexico, you could get bitten by the malaria the Anopheles mosquito, and you'll also you'll be affected by the malaria parasite. Of course, there are different types of plasmodia. That's the germ. You have the Plasmodium falciparum. 90% of the cases is Plasmodium falciparum, and Plasmodium vivax is 40%, which causes about 132 to 390 million cases, according to Price and collaborators in 2007. There is a new Plasmodium that has just been recently discovered. That's Plasmodium knowlesi, according to Cox and his collaborators in 2010. This is the main cause of what we call neuromalaria. In fact, Plasmodium knowlesi affects basically the brain. Okay, and then you have Plasmodium ovale, Plasmodium malariae, and that's it for the different types. Of course, if you talk about the endemicity of malaria, it has to do with the amount of the parasite that is found in the blood. The bigger the endemicity, the higher the parasitemia, and the greater the effects of the parasite in your system. So we talk about hypoendemic areas where you have less than 10% of the population affected. Mesoendemic, 11 to 50%. Hyperendemic areas, 51 to 74%. And holoendemic, greater than 75% of the population that are affected. Of course, that's the life cycle of malaria. That's exactly the same thing I was going to show you in the movie, but this is the diagram. Here you have the malaria, the mosquito, the female Anopheles mosquito, taking its blood meal, okay? And as it does that, releases the sporozoites into your bloodstream. These sporozoites migrate and go to the liver, where they attack the liver cells, okay? And produce what we call schizons, okay? These schizons are going to multiply, just in mitotic multiplication. That's one parasite dividing into 2, the 2 dividing into 4, 4 into 8, and so on. And when these schizons rupture, what happens? All of the parasites are released into the blood stream, and then they attack the red blood cells. These red blood cells will become very, very, very unstable in terms of their cell membrane. The membranes will be very weak, and that's how the blood cells would very easily rupture, and that will lead to anemia. Because of the anemia, the amount of oxygen that is transported from the lungs to the rest of your system is reduced, because it is the red blood cells, these red blood cells, that transport oxygen from your lungs when you breathe to the rest of your body. Now, if these cells are destroyed, you can imagine that you're breathing, but you're not transporting the oxygen from the outside into your system. And that's how the cells will go into some kind of ischemia. Ischemia means a drop in the amount of oxygen that you have in the cells, and the cells will start suffering, and then you start having all the symptoms of malaria that I'll show you in the next few slides. Of course, in the event that another mosquito comes to get a meal from somebody who is infected, it will be taking its meal, but it takes a meal alongside with red blood cells that are infected. Okay? So when they collect when they collect the parasites alongside with the red blood cells, it goes into their system, where the male gamete and the female gamete will now meet, and they will continue with the cycle of production of sporozoites. Okay? And so when this other mosquito comes for its meal, it takes the sporozoites and then transmits it to another person. All right? So that's the life cycle of the parasite. From the time when it's one mosquito is taking its meal to the time when another mosquito comes to take a meal, and the cycle goes on and on. Of course, leaving enormous damage to almost all the cells of the human body. Okay. So, of course, the erythrocyte membrane, like I said, will undergo certain modifications, and these modifications would usually result in, a rupture of the red blood cells, and that's how the individual will become anemic and become sick. It goes to his brain, the brain doesn't receive oxygen, and that's how they go into coma, and death ensues. Of course. Cytokines and toxins, this slide, I put it in just to show you the different ways the body tries to fight against the malaria. They try to produce what they call tumor necrosis factor alpha, gamma interferon, interleukins. All of these usually are the arms which the body tries to generate to fight against the malaria parasite. Of course, there are different things which the different systems of the body do so as to be able to efficiently fight against it. They talk about the upregulation of the endothelial receptor expression and the distribution of at the endothelial surface. The endothelial surface that's inside the blood vessels. Of course, you have physical disturbance of the host, such as fever. You have upregulation of nitric oxide production, which may cause local damage and sequestration. So when there is sequestration, there is actual physical blockage of the blood vessels that carry blood up to the brain. And that's will result usually in convulsion. And when the patient convulses and you don't treat him adequately and rapidly with intravenous quinine, definitely the person is slated for death. Of course, this is what I was just talking about. The red blood cells with modifications in their membranes would clot together, and they start by linking themselves with the endothelium. These are the cells that are lining your blood vessels. And when they get stuck there, they form a clot, and when the clot completely blocks the blood vessel, now the end organ will not receive any more blood, and that's how ischemia and death will follow, of course. In terms of diagnosis, you use what we call clinical criteria, you use microscopy. Today we have rapid diagnostic tests, and we also have molecular diagnostic techniques, which I wouldn't want to bother you guys with. Of course, these are the different types of Plasmodium. You have Plasmodium falciparum, vivax, ovale, and malariae. These are blood smears, the pictures when you're doing microscopy. In fact, when you're looking at the parasites under the microscope, this is what you get, or these are the different pictures you get for the different types of Plasmodia. Of course, this picture shows you a patient lying down because he's been vomiting. They had to put a nasogastric tube to be able to feed him, and they're giving him intravenous quinine, to be able to feed him, because this patient would also be vomiting. He has a lot of nausea and things like that. But the fastest way you can treat him is by using intravenous quinine, which will go directly into the blood system. Of course, malaria can be classified from a clinical perspective into uncomplicated malaria and severe malaria. Of course, uncomplicated malaria could be treated by anyone, and in fact, that's what we call the tip of the iceberg. That's what we see every day in clinical practice. But the severe malaria, usually, or sometimes, we don't see them because they die wherever they've been affected if they don't come to the hospital in good time. Of course, for you to be able to diagnose that, you have to take a good history. For the doctors out here, the take-home message is if somebody is coming from Africa, you've had a recent trip to Africa, say within the last week or the last 2 weeks, and this person comes up with a fever, joint pains, headaches, and all of that, the first thing you have to think about is malaria before you think about anything else. But of course, there could be other things which could have affected this person, but you have to think about that. You have to examine this person because there are definitely going to be signs and symptoms which you will be able to see, and you do the basic laboratory investigations which we have been talking about. Clinically, like I said before, the person will come with fever. Usually it's high-grade fever, could be low-grade. For some people, like us who have been living with malaria all our lives, it could, be about, in terms of temperature, 38 degrees centigrade, but it could be as high as 40 degrees centigrade sometimes. Pallor, joint pains, muscle pains, headaches. I've told you what happens when blood is not, or enough oxygen is not being transported to the brain or to any part of the body, any cell whatsoever. The translation is pain. Okay? So the pain could be found in the head, with headaches. It could be found in the muscles, muscle pain. It could be in the joints, and of course, the conjunctiva, in the eyes, the palms, and the soles of the feet will be pale, because what gives you the red coloration of your face is the hemoglobin which is found in blood. Now, if you don't have enough blood, what's going to happen? The coloration will go away, and that's how you become pale, okay? Of course, the spleen is one organ which helps to control, gather all of these red blood cells that have parasites in it, and therefore the spleen will be overworked and will turn to become enlarged in a condition which we call splenomegaly, okay? Of course, the platelet counts will drop. The amount of bilirubin will be very high, because each time the red blood cells split up, they release the protein which is found in blood called hemoglobin, and once hemoglobin is degraded, it produces what we call bilirubin, okay? So sometimes, if you look at the eyes of such a patient, they will be yellow, And if he passes urine, this urine will be yellow, showing that the amount of bilirubin is gone up. Of course, there are other manifestations which are non-specific. Like I said before, all the organs of the body will be affected. And that's how the lungs will be affected. The person will tend to increase the amount of breathing so as to compensate for the amount of oxygen that is not being supplied to the body. Of course, they can come off with chills, malaise, fatigue, excessive sweating, headaches, cough, anorexia, nausea, vomiting, abdominal pains, diarrhea, and so on. Of course, to be able to diagnose this, you have to do a thick smear, and you have the images which I showed you a few slides back. Of course, nowadays, there are rapid tests which could be used. There are little strips. Once you put the blood on the strip, it will show, it becomes positive and tells you that there's malaria parasite present in the bloodstream. Of course, if you have to treat malaria, uncomplicated malaria, you rely on a certain number of drugs, okay? Before now, we used to use chloroquine, but guess what? Chloroquine, the malaria parasite has developed resistance to chloroquine, and that's why we no more use chloroquine to treat malaria. So the WHO has recommended what we call artemisinin-based derivatives. You have other drugs like atovaquone, you have quinine, of course you have mefloquine and things like that. Treatment of complicated malaria, like I said, must be done with intravenous quinine, okay? You want to also replace the fluids that such a patient would have lost. If he's anemic, you want to give blood, and if you have pains, headaches, and all of that, you want to give drugs against all of that. So the take-home message is you have to be able to recognize anybody who has been able to travel to the malaria endemic zones and comes back home with a fever, comes back with a headache. You should not take it lying down. You should go to the nearest hospital and make sure he tells the doctor that he's coming from Africa or he's coming from a malaria-infested zone. Of course, there are certain prognostic features. From a clinical point of view, as the disease progresses, there is a slow loss of consciousness. Just somebody who is just listless and, with a flu-like syndrome, eventually becomes, obnubilated and eventually loses consciousness. And sometimes if you make the diagnosis and you start the treatment, within the next 24 to 48 hours, this patient will come around, okay? Of course, sometimes if so many blood vessels are blocked in the brain, the patient will start having convulsions because that's the way the brain translates the absence of oxygen, all right? So if you have more than 3 convulsions in 24 hours in a patient who has had fever and all of that, you should start thinking of malaria before you start talking about brain tumors and so on and so forth, which are also other possible causes of convulsions. Of course, from a biochemical standpoint, the kidneys are usually affected with serum creatinine of more than 3 milligrams per deciliter. If you check, look at the amount of bilirubin in the blood, usually it's more than 2.5 milligrams. If you look at amount of glucose, usually it's less than 40 milligrams per deciliter, okay? If you look at the eyes of the patient, you have hemorrhages in the retina. It's to tell you that malaria is a systemic disease. It doesn't affect just one organ system. It affects most of the organ systems in the human being. Of course, the whitening shows you lack of blood flow within the little blood vessels, which we call capillaries. Of course, this little boy was affected with malaria, and unfortunately, he didn't make it. Although he received his quinine intravenously, they came kind of, in the late stages, and the boy, a few hours later, died. What are the effects of malaria on the economy? Malaria usually is in poor countries. It has a direct impact on the environment, and the environment also has a direct impact on malaria. It usually would occur in areas where hygiene is poor, with bushes and littering, stagnant water, and so on and so forth. But of course, when an environment is, infested with malaria, the people who live therein will not have the possibility to go to work, okay? And that's how you have many hours of, working hours lost. You have people who are admitted in hospital, they have to pay the bills. Also, the community, if there are so many people in the community that are affected, the productivity of the whole community eventually is reduced. There are so many studies that have been carried, and in these studies, they've been able to demonstrate that countries or areas that are malaria infested have a very low per capita income. And so they will have difficulties in even responding to the disease. So it's like a vicious cycle, actually, okay? So here, all the conditions are rife for malaria to be able to thrive. You have the water on which the Anopheles mosquito thrives, lays its egg, and you have people living around here, in the bushes. Look at that. These people virtually are exposed to having malaria on a daily basis, okay? But all is not lost, because today it has been found out that the Anopheles mosquito usually feeds at about 2 a.m. in the morning. And so if you are asleep at about 2 a.m., that's the time when the mosquito comes to have its infecting meal. It's at that time that the infectivity is highest. And that's why it has been recommended internationally that to be able to control malaria, you have to sleep in mosquito-treated nets, bed nets. These nets have certain chemicals which are detrimental to the mosquito. So when the mosquito comes and sticks on them, they wouldn't be able to fly away again. They would just get destroyed as they get entrapped into the mesh of the mosquito net. So it's one of the most effective tools that the international community is now using to fight against malaria. Of course, the other thing we want to do is use insecticides to be able to destroy malaria in the niche, in all the environment. One thing the United States has been able to do, or the developed world has been able to do to fight malaria, is environmental sanitation, where most of the things you use are, put together and recycled, and so they don't, lay about to constitute, the niches for the Anopheles mosquito to be able to reproduce. Secondly, the urbanization that's going on out here has made it possible for the water to percolate as soon as rain falls or water from any source. This water percolates and is carried to and recycled. So malaria has very, very little chance out here. But in other countries, in Africa, in the Americas and so on, without these systems, malaria, has the possibility to take its toll on the environment. That's it. Thank you so much for your kind attention, and I'll be happy to have any questions. Thank you. Yes, ma'am. Yes.
Some of us are aware of the NET program. We had a program here 2 years ago describing it and a film on it. A wonderful presentation. How effective are those nets, those huge nets that cover a whole family overnight? How effective has that been in preventing malaria? Because if it really is working, that program is still ongoing here in this country, and we could all be donating to it anytime we have the opportunity.
Yes, thank you so much. And don't hesitate to do that if you have the opportunity to do so, because it has been shown to be very, very effective, in fighting against malaria. In fact, it has been shown that pregnant women who sleep under those mosquito nets have fewer episodes of malaria during their pregnancy. If you look at the areas, before I came to the United States, there was a lady, one singer, who donated about 9 million mosquito nets to the Cameroonian government. And those areas that had received the mosquito nets, we found the rate of malaria parasite, significantly lower than the areas that had not yet received it. The problem with the mosquito net is that you cannot put the mosquito net around you to be moving around. We say mosquitoes would feed optimally at about 2 o'clock, but if you're moving around in the evenings, okay, without any solution, or any repellent to repel the mosquitoes, you still could be bitten by the mosquito, and you would come off with malaria, okay? So for the mosquito nets to be very effective, it has to, one, to be impregnated with the anti-mosquito chemicals. But also, it has to be used by the whole family, and that's why each family has, for 2 people have to sleep at least in 1 mosquito net, because you cannot buy as many mosquito nets as there are people in your family. It's just not economically practical. But the people who use the mosquito nets and they use them consistently, usually we come up with fewer episodes of malaria attack. Yes, please, madam.
I have 2 questions.
Yes.
Number 1, how long is the effectiveness of the mosquito netting? And secondly, why is not Australia involved?
Thank you so much. That's a wonderful question. The mosquito, the product which is put on the mosquito net lasts for at least 5 years. Yes, for at least 5 years. So once it is impregnated, you have to renew it after 5 years. Now, Australia may not be involved because Australia is further down, towards the South Pole. And if you look at the temperatures in Australia, they're much lower than you would find.
But up in the northern part, near Darwin.
Yeah, you could in the northern part.
Very damp.
Yes, if we went back to this slide, you see, I told you about the optimum, the belt, which malaria, thrives best. I told you malaria, the mosquitoes would reproduce optimally at a temperature of at least 15 degrees. The least temperature is 15 degrees. I'm talking of 15 degrees centigrade. Now, below 15 degrees centigrade, the mosquito will not thrive. It will not be able to reproduce. And remember, the mosquito that transmits malaria is the female anopheline mosquito, okay? Because it uses blood, human blood, for the maturation of its eggs, okay? So all other forms of mosquito, the Culex mosquito and so on, do not transmit malaria. I wonder if your question is answered. Okay. Yes, sir.
One word about the next, and that is that I believe it's only $10 to cover a family for all of this amount of time, and I would be happy to supply the address of where you can deal with this. If Sandra or maybe can supply me with the emails or addresses of all of you.
Okay, that would be wonderful. Thank you. Yes, sir.
Is a contagious disease. With so many occupying such a limited space, especially in sleeping quarters, is it contagious?
Contagious in the sense, the real sense of the word, no. If somebody has malaria and you touch them, they will not transmit the malaria parasite to you. Or if somebody who has malaria coughs, the sputum thereof will not transmit malaria. But if the blood of somebody who has malaria, and we've seen that very often, when blood is transfused to some patients, needing surgery, for instance, 48 hours later, they come up with a fever. So you've been able to transmit the parasite through the blood of the donor to the recipient, okay? But otherwise, the only other way malaria can be transmitted is through, from one person to the other by the malaria, by the Anopheline mosquito. You don't have malaria by touching or by, by hugging or by kissing or something. So it's not contagious in the real sense of the word. Okay. Yes, ma'am.
What research is being done to come up with an inoculation so that the populations in these, along those belts, might be immunized?
Yes, thank you. In actual fact, there is a lot of research work going on right now to come up with a vaccine. There is a consortium which is being sponsored, I think, by the Bill and Melinda Gates Foundation to come up with a vaccine against malaria. But guess what? The malaria, just like the HIV virus, changes its antigenic properties every so often. And that is why, for so many centuries, or so many decades of research, we've not been able to come up with a vaccine which could be used universally. But I think there is a lot of work that's being done, and hopefully someday we should be able to have a vaccine. Yeah. But we rely, for now, on prophylaxis. For pregnant women, for children under 5, we give them prophylactic, what we call intermittent prophylactic treatment. Before we talked about just prophylaxis, but now we actually give whole doses, to pregnant women every 3 months, so as to try to avoid the effects of malaria on their unborn children. Yeah, thank you. Yes, ma'am.
If you happen to get malaria, get treated, and recover, it seems like I've read that you can forever, for the rest of your life, you can get fevers over and over again. It recurs, and does that mean that your blood always carries it?
Yes and no. I will go back to the slide on the life cycle of malaria. So you see exactly, oops. Yeah, there we are. If you look at this slide, you will see there is part of the life cycle of the malaria parasite that goes on in the liver. You also, one thing that has not been mentioned here is the part of the life cycle that occurs in the spleen, okay? So these porozoids, it's very, very difficult to eradicate them. Now, when you treat somebody for malaria, usually you treat you'll be able to kill the parasites that are found in the circulating blood. And that's why sometimes you have to give them treatment for a long time. Or somebody who has come off with a bout of malaria, you have to give them prophylactic treatment every month or every other month. Okay? That's one thing. This other thing is, if you don't remove this person from that environment, another mosquito would come back and give him another parasite. It doesn't mean the treatment which he received the first time wasn't effective. The treatment could have been effective, but The person has simply been reinfected with the malaria. So you have recrudescence and you have reoccurrence. So those are two different notions which I didn't want to go into. Okay, but usually those are the two principal reasons why you come off with other bouts of malaria. And so if you're going to live in such a zone and you know you don't have the natural protection which people who live in that environment should have, then you always have to take your prophylaxis. Okay? Yes?
I have a question. So this particular mosquito, and it will only spread this virus into humans, not animals, correct?
Correct. Unfortunately, the plasmodium does not live in other animals. It only lives in the human beings. You imagine if the parasite had to do anything to the mosquito, what would happen? If the parasite, the mosquito is just a vessel, you know, it just carries the plasmodium, but doesn't do anything to the mosquito itself. Okay? So most animals, even if the Anopheline mosquito, you know, took a blood meal from an animal, the parasite wouldn't thrive, it would not survive. Okay?
So the other part of that then is, is there anything being done to kind of study these particular mosquitoes to control that population? That's the only mosquito that carries that.
Yes, it's not only the Anophelines, but it must be the female Anopheles mosquito. It's the female Anopheles mosquito. Like I told you, it's because the female Anopheles mosquito needs blood for, you know, it to complete its own reproductive cycle. So the other mosquitoes, like the male Anopheles mosquito, Culex mosquito, or what have you, they don't need it, and they don't feed on blood. So it is just this mosquito. So I think what you're trying to refer to has to do with some biological warfare against the mosquito. You know, like if we could identify you know, to have mosquitoes that would, or something in the saliva of the mosquito that causes it to tolerate the parasite, that would be great. But so far, nobody has been able to identify what is it that causes the parasite to be tolerated in the mosquito. Perhaps if somebody found that someday, we would be able to have, you know, to win the war against mosquito malaria. Yes, please, sir.
I spent 2.5 years in the Philippines.
Pardon me?
World War II. We took Adamant every day. Nobody got malaria. There must be other side effects because I don't know. I don't have it. I had no problem with malaria for 2.5 years.
Oh, and you've been in where you've been in the Philippines?
Yes.
Oh, okay, but that's great. But it is also true that there are people living in Africa who miraculously have not been able to have malaria, but they're living in a malaria-infested zone. So there are so many unanswered questions, you know, in terms of research about malaria. Like I told you, just like the HIV, the malaria, the plasmodium has the capacity to change its antigenicity. It has the capacity to do all kinds of tricks, you know, to avoid being destroyed for good. Are there any other questions? Yes, ma'am.
I was just thinking, I lived many years in Africa, and I always took malaria suppression pills.
That's right.
I took them every week, so, you know, and I never got malaria.
Good. Yeah, that's what is basically recommended right now. Mm-hmm. Yes, Sandra?
So this isn't about malaria, but something else that might be infectious. It's, I'm interested in knowing what the impact of your visits to America have had measurably or aesthetically or any way on the practice of your medicine since then?
Thank you so much. I think it's been a two-way traffic. There's been a lot of impact. My visits to the United States have impacted me a lot, and I have been able to, pick a certain number of things here in the United States. Like right now, there is a software which I came up with, an electronic medical software which is being implemented in my hospital, okay? But of course, discussions like this and other fora, while I was at Emory, while at NYU, we've been able to exchange things, and there's so many people who have benefited from such discussions. So I think it's been a two-way traffic, and I'm really very, very appreciative of the fact that this international collaboration is something which should be encouraged, because it will be difficult for all of you guys to go to Africa to be able to see, some of the things we're talking about today. But of course, it's not everybody who will be able to leave Africa to come over here. So those of us who come will be able to carry information back and forth, and I think that's something to congratulate the United States government for, and to encourage to a greater extent. Thank you.
Thank you so much. I'm sure we all learned a lot, and I think that you are absolutely right that it's a two-way street, and we'd like to keep those roads open, continue to open. I hope you'll come back, and I hope we'll go to Cameroon to see you there.
Thank you. Thank you so much.
Next luncheon is on March 30th, Alita Black, talking about the 4 freedoms that Franklin Delano Roosevelt invented, and looking at them into the future. So they have a future, and it's being kind of created right now. Thank you.
Thank you for coming.